Welcome to Advances in Multiple Sclerosis, provided by the consortiums of MS centers in collaboration with the France Foundation. My name is Dr. Carrie Michelle Hirsch. I'm the director of the Multiple Sclerosis Health and Wellness Program at the Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas, Nevada. I am also the Associate Program Director of the Neuroimmunology and MS Fellowship at the Cleveland Clinic in Las Vegas, and I'm an Associate Professor of Neurology. Today's learning objective is to develop individualized treatment plans, incorporating the team approach that addresses the multifaceted problems related to multiple sclerosis. Let's start with a case presentation to help hone in these concepts. We will start with the patient description history. A 25-year-old African-American woman presented with acute onset of left eye retroorbital pain along with left frontotemporal headache. Within 2 weeks of onset, she developed subacute left eye blurred vision that was described as looking through cellophane and slowly worsened over another week. 3 weeks after her symptoms started, she was unable to read words out of the left eye due to a gray secocentral scotoma, and she also noted to the provider that the colors looked muted. She could not drive due to depth perception impairment. She was referred to an ophthalmologist who suspected optic neuritis. The patient was treated with high doses of intravenous methylprednisolone with full recovery of her vision within 1 week of treatment. She has no pertinent past medical or surgical history. She's in a serious relationship with her boyfriend but does not currently have any children. She doesn't have any prior history of MS or other autoimmune conditions in her family. And she is not currently on any prescription medications, and she takes a multivitamin daily. Her neurological examination showed pertinent findings of mild temporal disc pallor behind her left eye. She had hyperreflexic deep tendon reflexes globally throughout, and she had a left extensor plantar reflex. She also had mild dysmetria in the left leg and dysdiadochokinesia in dysmetria involving the left arm. On her gait exam, she had mild instability with her tandem gait, though she was able to complete a timed 25-foot walk in 5.4 seconds, had moderate disability in her 9-hole peg test, and had an EDSS of only 2.0. So let's look at her initial brain MRI findings. So as we can see that are denoted by the red arrows, she has a high T2 flare hyperintense lesion burden that is characteristic of multiple sclerosis that meets dissemination in space based on the morphology and location of the lesions in more than one topographical compartment that is characteristic of MS that includes the periventricular, juxtacortical, and posterior fossa. Radiographically, she also meets dissemination in time that is represented by a combination of enhancing and non-enhancing lesions on the initial brain MRI. She has overall a fulminant radiographic lesion burden with more than 15 GAD-enhancing lesions on her initial MRI. Looking at her cervical spinal cord MRI, we could also see that there is a relatively high lesion burden throughout the cervical spinal cord, showing a combination of discrete and patchy lesions in a distribution quite characteristic of multiple sclerosis. And there are also a smattering of posterior fossa lesions that can also be seen on these sagittal images. So we can say that she also has spinal cord lesions that are characteristic for multiple sclerosis. There were no GAD-enhancing lesions in the spinal cord. So the initial question, does this patient meet 2017 McDonald criteria for multiple sclerosis? And the reason for that is because according to the 2017 McDonald criteria, she meets dissemination in space and dissemination in time radiographically, and she initially presented with a clinically isolated syndrome with a characteristic presentation of an acute CNS demyelinating event, otherwise known as optic neuritis. So she meets these criteria because she has more than one T2 lesion in at least two, and in this case, all four compartments that are topographically characteristic of multiple sclerosis. And she also meets the dissemination in time criteria by MRI because she has a combination of enhancing and non-enhancing lesions on the initial scans. So the next question is, how worried should you be about this patient? Should we not be worried because the patient is young, only presented with one clinical attack and responded favorably to steroids? Or should we be worried because she's at risk for aggressive features? So the answer to that question is B. We should be worried about this patient. This is a slide that summarizes the factors that are associated with more aggressive disease course for which the patient does meet quite a bit of these factors. Such clinical factors that are associated with a more aggressive disease course include older age at onset, male sex, non-white ancestry, either by race or by ethnicity, pyramidal posterior fossa or spinal cord involvement, frequent relapses, incomplete recovery from relapses, multifocal involvement at presentation, and early cognitive dysfunction. For our patient, she has a non-white, otherwise African American or Hispanic background, so that is a negative clinical factor. But she does have many paraclinical factors that are associated with more aggressive features. That includes high MRI lesion burden at initial presentation, and she does have MS lesions that are located in the posterior fossa, including the brainstem cerebellum, and she also has lesion burden in the spinal cord as well. Other factors that we have not already discussed is early OCT changes on optical coherence tomography, the presence of oligoclonal bands on a cerebrospinal fluid test, and vitamin D deficiency. So I would say that I'm quite worried about this patient, predominantly because of the high lesion burden and the number of GAD-enhancing lesions that she has throughout her brain. So let's again go over the positive and the negative prognostic indicators for this particular patient. So she has some good prognostic indicators. She is female. She has a relatively young age at onset. She did have complete relapse recovery following a course of high doses of intravenous methylprednisolone, and she doesn't have any other noted comorbidities. However, as we had already discussed, she does have a fair number of negative prognostic indicators that makes us a little bit more worried about the patient. So let's review some practices and principles of treatment for multiple sclerosis. So the vast majority of patients who are diagnosed with multiple sclerosis are initially diagnosed with a relapsing form, either clinically isolated syndrome, relapsing remitting MS, and then there's also the preclinical stage of multiple sclerosis, otherwise known as radiologically isolated syndrome. Our overall goals of treatment are to reduce disease activity and to slow accumulation of disability. And we also want to make sure that we are diagnosing early so we could treat early. In that way, we can maximize neurologic function and reserve, and for it to be difficult to recover what has been lost if we do not treat early. It is also recommended that once a patient is started on a disease-modifying therapy, there is regular monitoring clinically, radiographically, and for safety purposes, and they are very paramount for chronic MS management. We want to make sure that we are improving safety and adherence of disease-modifying therapies by frequent visits with the patients. We want to improve identification of subtherapeutic response to treatment, again, through periodic monitoring with the patient, with them coming in to review their clinical, radiographic, and safety status. And also, we want to improve the patient and the care partner engagement, which goes along with the shared decision-making. When we do this, we are able to foster trust and forge the patient-partner relationship with the physician. So there are various MS Coalition consensus statements on disease-modifying therapies, and while there is no consensus on which disease-modifying therapies are started and subsequently switched to, we do have various treatment practices on board that are currently recommended. So disease-modifying therapy should be initiated as soon as possible after diagnosis of relapsing MS. We also want to consider high efficacy therapy in newly diagnosed patients who have more highly active disease, similar to the case that we just presented, where we have a patient coming in with more than 15 gadolinium-enhancing lesions on her initial brain MRI. We can consider escalating to high-efficacy therapy if there's evidence of breakthrough disease, if the patient, physician, and care partner decide on an escalation treatment approach. In that regard, starting on a disease-modifying therapy of lower efficacy, but maybe have better safety parameters. But if there is evidence of breakthrough disease, we want to make sure that we are escalating that treatment. We need to make sure we're accounting for time to drug effect. Many of the disease-modifying therapies take various amounts of time to reach their optimal effectiveness. But we also want to make sure that we're minimizing the washout duration when possible, but promptly switch when able. And this is a fine tactic that needs to be incorporated into that decision-making. Treatment should be continued indefinitely. Well, there's some schools of thought of reconstitution therapies and whether or not a subsequent disease-modifying therapy is necessary, and then whether or not patients can discontinue treatment as they are getting older and the benefits and risk factors and ratio are no longer favorable. So that is for another time. Disease-modifying therapy should be initiated and switched via a shared decision-making approach. So we want to make sure that we are optimizing therapy before irreversible disability accumulates. So there is a fine window of opportunity for our patients who have relapsing MS. The best time to initiate therapy is as early into the diagnosis of relapsing MS as possible. As the disease worsens and there is a more neurodegenerative state as the patient begins to age and the MS in turn begins to age, there is less benefit from the disease-modifying therapies just because of the lack of innate repair that comes from our disease-modifying therapies. So earlier on in treatment is going to be best for our patients in decreasing the risk of accumulating disability over time. But really, it is a fine balancing act, balancing with the patient and the care partner on starting on a lower efficacy disease-modifying therapy, maybe with better safety and risk opportunities, or starting on a highly effective therapy where the safety and the risk may be more prominent compared to some of the lower efficacy treatments. So at the crux of this is the shared decision-making approach. So what does that look like? Well, there are many factors to consider when we are embracing the shared decision-making approach with our patients. So there are a number of patient-related factors that are involved. This involves reviewing the preferences that the patient and the care partner have, going over the patient's risk tolerance. How amenable are they to starting a highly effective therapy with a certain number of safety risks? That is going to be very important to clarify when discussing an initial disease-modifying therapy or later switching them to another one. We also want to make sure that we have a strong understanding of their comorbidities that may impact the safety of the disease-modifying therapy. And of course, reproductive status. Is the patient planning on growing her family? And if that is the case, we need to make sure that we are integrating decision-making into the conversation. There are also a number of disease-related factors as well. So how severe is the person's MS in terms of number of clinical relapses? What is the status of their recovery? How much T2 lesion burden they have at baseline? How much activity on the MRIs are at baseline? All of that is going to be very, very important to consider when deciding on an initial disease-modifying therapy, whether we start them on a highly effective therapy, which may be more appropriate in that case, versus starting them on a lower efficacy therapy if they have a milder disease course. We also need to know the phenotype. Is it a relapsing form of MS versus a purely progressive form of MS? That does have a strong implication in terms of which disease-modifying therapy we choose. We also want to have a good understanding of the prognostic signs. So that is in relation to the aggressive features that we talked about in the previous slide. If the patient has more aggressive features or risk factors, then we might want to start them on a more highly effective therapy right off the bat. Risk of not treating or under-treating patients. So this is another part of that shared decision-making approach. So it's not necessarily do we start on highly effective versus lower effective, but also what are the risks of not treating? If there is a patient who is reluctant to start on a disease-modifying therapy, what would that look like down the line long-term? And how would that impact their disability and their quality of life and function at home? Treatment-related factors. So these are the factors that are specifically related to the disease-modifying therapy itself. So having an understanding of how effective it is, going over the safety, the tolerability features is important. How much monitoring is needed, when it is needed, and of course the dosing route, the administration, and the frequency is going to be important for the patient to understand when selecting a treatment with the physician and the care partner. And then, of course, system-related factors. So insurance coverage, of course, and then access to services. So if we have a patient who lives in a remote location who doesn't have any access to an infusion facility, selecting a oral therapy or self-injectable therapy may be more reasonable than selecting an infusion therapy where the patient will not be able to access an infusion facility easily. So let's get back to our case. Let's see what a shared decision-making conversation might look like. So we are joining the conversation midway. So the physician, myself, has explained to the patient that our MRI shows several lesions in the brain and cervical spinal cord in areas that increase the overall risk of disability. Also, the lesions on the brain are newly formed and highly active. And now the patient is ready to discuss therapy. So the patient understands that because of the severity of disease prevention, a highly effective disease-modifying therapy is warranted. So the physician has informed the patient about the various options and the need to together identify the best choice for the patient, namely a high-efficacy disease-modifying therapy that also meets the patient's preferences on risk, safety, and tolerability, as well as access to the medication and pregnancy planning in the future. So let's see what happens next. So now that we have discussed the options, I'm curious, what are your thoughts?
Thanks, Dr. Hirsch. I want the medicine that will be best in preventing my MS from getting worse and other symptoms or disability adding up. Based on what we talked about, I'm thinking that an infusion therapy will work best for me. I'm afraid that I will forget to take a pill every day, and I don't want to inject myself. It sounds like the infusions are highly effective, and I can get to an infusion center fairly easily, and I won't have to worry about dosing myself. I don't plan on getting pregnant for at least the next 5 to 10 years. Do you think this is a good way to go?
Absolutely. Based on your preferences, natalizumab, ocrelizumab, ublituximab, and alemtuzumab would all be reasonable choices. As I recall, your JC virus antibody status is negative, but you are more prone to infections like upper respiratory tract infections and urinary tract infections. Is that right?
Yes, that is correct. Is there an option that would not significantly lower my immune system?
So in that case, natalizumab would be a great disease-modifying therapy for you. It is administered every 4 weeks, but we can increase the interval to every 6 weeks to lower the overall risk of progressive multifocal leukoencephalopathy, or PML. Further, it is highly effective, will reach its optimal effectiveness within the first 2 to 3 months of starting the medication, and it won't lower your immunity as much as some of the other options. You'll have periodic lab work and a repeat brain MRI to monitor your response and safety, and I'll see you in 3 months for a clinical evaluation. How does that sound?
This sounds great, Dr. Hirsch. Thank you for reviewing my options with me in such an open and compassionate way. I feel so relieved and comfortable now.
So using all of the information from the shared decision-making that you just heard, this is a summary of the therapy selection, factors, and decision as it relates to the different factors that we have previously talked about. patient-related. So the patient we recognize has concerns about infection risks with immunosuppressive therapies, but she did have a preference for a more highly effective treatment to minimize her overall risk of having a disabling relapse. She's of African American race, so we are putting that into the equation that there are some more aggressive risk factor features. And the patient is not planning on pregnancy planning for at least 5 years, so we have a little bit of time to decide on what would be the best disease-modifying therapy strategy moving forward for her to safely grow her family. In terms of disease-related factors, there's a high lesion burden with fulminant brain MRI activity. So remember that she had 15 GAD-enhancing lesions. That meets criteria for highly active disease. She had many posterior fossa and spinal cord lesions throughout, and she ended up presenting initially with an optic neuritis, which is actually more of a low aggressive feature, but we can always consider that into the equation when we are talking about the best initial disease-modifying therapy approach. In terms of treatment-related factors, she had a GC virus antibody that was negative. So in terms of safety of her starting natalizumab as initial disease-modifying therapy, we're pretty on point. She does recognize that monitoring is needed. And we also do recognize her preference for infrequent administration due to a busy schedule, concerns about forgetting to dose her medication at home, and not wanting to self-inject. So we are putting her preferences into account when we are selecting that initial disease-modifying therapy. Again, this not only will help improve overall adherence to the disease-modifying therapy strategy, but in an informed decision-making approach, we're also fostering that physician, patient, and care partner relationship and increasing trust overall. System-related factors, so we recognize that getting other monoclonal antibodies infused in that region can be challenging, where it can take upwards of 3 months to get to the first initial infusion. This patient, because she has highly active disease, does not have that time. So we really need to make sure that we are selecting a therapy where the onset of the treatment can be dosed early on. So let's review the 12-month outcomes. So the patient has now been on natalizumab for 12 months. She has not had any relapses. She has no new lesions on her 6 and 12-month brain MRIs, and her 6-month cervical spine MRI was also stable. She has tolerated her infusions very well without any adverse effects, and she has not had any infections since starting disease-modifying therapy. Her GC virus antibody serostat has continued to remain negative with an index of 0.15, and the last time we checked was 2 months ago. So let's look at the key takeaways from today's talk. Treatment should be started early in relapsing MS. There are 2 treatment approaches for initiating disease-modifying therapy, early, highly effective versus traditional escalation approach. There are multiple factors that need to be considered when choosing a therapy or a therapeutic strategy. So we need to make sure that we are considering patient, disease, treatment, and system-related factors. The overall goal of disease-modifying therapy is to preserve the neurologic reserve. There is a low threshold to switch therapies if there's evidence of breakthrough disease, either through clinical relapses, new MRI lesions, or disease progression. And remembering that time is brain. There is no more one-size-fits-all dogma. There is ongoing need to balance efficacy, safety, and tolerability of therapeutic interventions for each patient in a personalized manner. Shared decision-making to engage the patient and care partner are key for selecting and switching disease-modifying therapy. And emerging data do suggest having a more aggressive treatment approach. For example, early highly effective therapy, especially for patients who have highly active disease and risk factors for early disability, or earlier DMT escalation before disability accrues if the patient, physician, and care partner elect to start on a lower effective disease-modifying therapy right out the bat. Thank you so much for listening. Please feel free to fill out the evaluation to claim CME credit.